the wall area is around 3 to 4 centimeters square. So if you look at into the diagram, you see here, this is the aortic wall leaflet, aortic wall. This is located between, this is left ventricle and this is ascending aorta. In between, there is an aortic wall. During the ventricular systole, the blood pumps from ventricle into the aorta. During that phase, aortic valve is open. Okay, so from above the picture, it opens like this. And during the phase of ventricular diastole, you see this right side diagram. The aortic valve closes and it prevents the regurgitation of blood from the aorta into the left ventricle during the phase of ventricular diastole. Okay, if you look at the over surface area, this is the closure picture. Okay, so coming to the structures that are present in the aortic wall. Aortic wall consists of usually one is wall cusps, and second one is annulus, and third one is commissures. Coming to the cusps, three leaflets are there. Leaflets is a semi-lunar leaflet or half-moon shaped leaflet. The main function of this leaflet is mainly it's a half-moon shaped or semi-lunar appearance. And coming to the annulus, annulus is a structure that is it's a collagenous structure that supports the valves or cusps. It's mainly located between the interventricular septum and aorta. And third one, the commissures. The commissures are the structures that attaches the free edges of the aortic wall leaflet to the aorta. So these are the three structures that are present in the normal aortic wall. That's annulus or aortic ring. It's between the junction of aortic valve and ventricular septum. Half-moon shape, and commissures. These are these structures attaches the semi-lunar free edges of the semi-lunar cusp to the aorta. These are the three parts in the aortic wall. So if you see, there are three cusps are there. One is right, second one is left, and third one is the posterior. Right coronary, right cusps or right coronary aortic cusp, where the right coronary artery opens. And here you see the left coronary aortic sinus or left cusp. Here it is the non-coronary or posterior cusp. These are the three cusps surrounded by the annulus. Then if you take the section overview, here you see this is the ascending aorta row where the semi-lunar valves are attached. It's the overview or superficial view. If you take a cut section, you see here this one is the aortic row and these are the three semi-lunar cusps. And here it is the free border and this is the height of the cusp, and this is called coaptation zone. This coaptation zone plays a main important role in closure of the aortic wall. In this area, the aortic wall leaflets are closed. So why you discussed here, I'll tell later. So if you see the normal versus defective aortic wall. If you see the upper picture, the normal aortic wall during the ventricular phase or ventricular systole, the blood pumps from the left ventricle into the aorta. Here, during the phase of ventricular diastole, aortic wall closed, the blood doesn't regurgitate into the left ventricle. If you take a defected one, in this, you see this lower one. Here, during the phase of ventricular systole, the blood ejects from the ventricle into the aorta. But during the phase of ventricular diastole, there is inappropriate closure of the aortic wall that leading to rejection or retrograde flow of the blood from the aorta into the left ventricle. Then, why there is an aortic restriction? So already you know what are the parts in the aortic wall. One is leaflets, second one is commissure, and third one is aortic. So any damage or any dysfunction of aortic wall leaflet, because this maybe rheumatic, that leading to aortic restriction, or already told in the previous class, annulus. So is there any problem in annulus or ascending So that is the important thing. Coming to the 3/4 of the patients with aortic restriction, there is increased instance is the male patient was not because the cases of male, because one is increasing in the male, increase of males, there is an instance of bicuspid always the instance is and the Marfan syndrome and some Ehlers Danlos, all these things, ankylosing spondylitis are increased instance in the male compared to the females. So because of that, aortic regurgitation is more commonly seen in male compared to the females. But whenever there is an aortic regurgitation associated with other valvular disease like mitral valve, most commonly observed in women because rheumatic etiology is more common in women. And at the same time, the aortic regurgitation is the instance, prevalence, and increased severity increases by age progresses. That's the one thing we have to remember. And other one, if the patient is presented with bicuspid wall or some other connective tissue diseases like Marfan's or some other connective tissues, they present very early compared to the late age. So rheumatic, congenital bicuspid wall, connective tissue diseases, in these cases, they are present early rather than the later age. So coming to the etiologies, different etiologies. What is the main pathophysiology behind the AR? One is leaflet abnormalities, either damage or dysfunction. The second one is aortic root or ascending aorta dilatation. So what some examples for the leaflet abnormalities? One is rheumatic fever. Rheumatic fever or rheumatic etiology is most common in developing countries rather than the developed countries. And endocarditis, trauma, bicuspid aortic valve, rheumatoid arthritis or myxomatous degeneration. All these are some of the examples for coming to the root dilatation. Aortic root or ascending aorta dilatation. Common causes for this is systemic hypertension, aortitis, or ankylosing spondylitis. Some other abnormalities like Marfan, Ehlers Danlos, all these presented with aortic root dilatation or aortitis or ascending aorta dilatation. These are some examples for the aortic regurgitation. So, etiologies, one is leaflet abnormalities, second one is aortic root dilatation or ascending aorta dilatation or aneurysms. Examples for leaflet abnormalities, most common is rheumatic fever, most commonly seen in developing countries. Endocarditis, that's again common in rheumatic etiology or rheumatic diseases. Trauma or bicuspid aortic valve, rheumatoid arthritis or myxomatous degeneration. These are the common examples for leaflet abnormalities. And hypertension, systemic hypertension, aortitis, reactive arthritis, ankylosing spondylitis, all these are commonly presented with aortic root dilatation. So if you see this picture here, aortic wall, there are some nodules over the aortic wall. So these nodules most commonly due to the rheumatic diseases. And coming to this picture, here there is a congenital bicuspid aortic wall. Here there is an annular dilatation. That annular dilatation leading to inappropriate closure of the valve leaflet. And third one, here some infective etiology like endocarditis. Here the walls are coaptation of walls are normal, but here what happened? There are rupture of the wall leaflets because of the infection. So like this, there are many etiologies for the aortic regurgitation. So to discuss, there are three etiologies. Two etiologies. One is leaflet abnormality, and second one is aortic root dilatation. So if you see this picture, here is the annulus. This is the coaptation zone. Coaptation zone is the zone where the wall leaflets are approximated or closed. If is there any annular dilatation, the coaptation zone is narrow, and further annular dilatation that leading to the aortic regurgitation. Okay, this is the cause for the aortic regurgitation in annular dilatation or dilatation of the ascending aorta. Okay, what are the common causes of acute AR? So we are talking about the chronic AR. We are not talking about acute AR now. So what is the pathophysiology? Pathophysiology, the common pathophysiology here is the inappropriate closure of the aortic wall leaflet. What's the main defect here? During the phase of ventricular diastole, there is inappropriate closure that leading to regurgitation of blood from the aorta into the left ventricle. So what happened? We get the volume in the left ventricle increases. That is regurgitant volume overload. So what happened? The ventricle receives blood from the left atrium at the same time from the aorta. So volume in the left ventricle is increased. There are compensatory mechanisms activates. What are the compensatory mechanisms? One is left ventricular dilatation. Left ventricular dilatation is due to left ventricular and diastolic volumes, increased left ventricular and diastolic volumes, and increased compliance in the chamber. So, increased left ventricular hypertrophy. We discussed in the MR session that there is the eccentric hypertrophy rather than the concentric hypertrophy. Eccentric hypertrophy that leading to chamber dilatation. All these things are stimulated by the increased end diastolic volumes or increased LV afterload. So what happened? These compensatory mechanism activates that leading to decreased left ventricular and diastolic pressures. Because of that, there is adequate forward stroke volume or adequate cardiac output that leading to sufficient coronary perfusion. So there are no symptoms up to this stage. Whenever there is steady increasing in the regurgitant volume, that leading to increased ventricular dilatation. So there is a stress over the left ventricular wall or myocardium. After that, left ventricle unable to hypertrophy or fail to hypertrophy to maintain that pressures. So that leading to contractile dysfunction of the left ventricle. This is the stage we call the decompensated stage of left ventricle. So once the left ventricle went into decompensation, there is increased left ventricular and diastolic pressures. And because of the contractile dysfunction, there is decreased ejection fraction and also stroke volume and cardiac output. Once decreased cardiac output or decreased stroke volume, that exert backward pressure over the left atrium. Once the left atrial pressures are elevated, there is a backward pressures over the pulmonary veins into the pulmonary circulation. There is a pulmonary congestion that leading to pulmonary arterial hypertension and right heart failure. So this is the main pathophysiology. So the first change is because of the regurgitant volume, left ventricle chamber is enlarged or left ventricular dilatation. Why there is a left ventricular dilatation? Because of the volume in the left ventricle at the end of diastole. Why there is increased volume? One is the volume from the left atrium and the volume from the regurgitant chamber. Ventricular and diastolic volumes increase. So increased volume and increased chamber compliance that leading to dilatation. So what is the other compensatory change? There is a hypertrophy. Hypertrophy, what we discussed earlier in mitral regurgitation, that is eccentric hypertrophy. That means the sarcomere fibers attaches one after other, that leading to chamber dilatation. All these things due to elevated end diastolic volumes. So these compensatory mechanisms activated and that decreases the pressures in the left ventricle. If the left ventricular pressures is relatively low, the left ventricle function is normal, the left ventricle maintains adequate stroke volume or cardiac output. So at this level, patient doesn't have any clinical symptoms. Okay. So once the volume is going on increasing regurgitant flow, there is a further ventricular dilatation. The ventricular dilatation shows the pressures over the left ventricular wall. That after that, some period, the left ventricle unable to hypertrophy to maintain the afterload. So that leading to a cardiac dysfunction or contractile dysfunction of the left ventricle. Once the contractile dysfunction is there, the ejection fraction is decreased or the stroke volume is decreased or cardiac output is decreased. So once the stroke volume or cardiac output is decreased, there is increasing pressures in the left ventricle at the end diastole. So increased pressures in the left ventricle that exert a backward pressure over the left atrium. That left atrial pressures are elevated. Once the left atrial pressures are elevated, there are pulmonary venous congestion, that leading to right ventricular pulmonary arterial hypertension leading to a right heart failure. Okay, this is the pathophysiology. So all the symptoms are mainly due to, one is congestive heart failure, that is because of left ventricular failure, and at the same time the right heart failure. So both due to congestion and decreased cardiac output. The congestion is the backward failure and the decreased cardiac output is the forward failure. So both left ventricle and right ventricular failure that gives the symptoms in patients with aortic regurgitation, any stage of decompensation. And the second one, the main other clinical feature is angina. Angina in case due to decreased coronary perfusion in the phase of diastole in decompensated state. Okay, this is the pathophysiology of chronic AR. If you look at this picture, the first one, what's the difference between acute to the chronic here? In the first one, there is acute regurgitation, acute aortic regurgitation. What happened in acute? The regurgitation of blood from the aorta into the left ventricle. But here there are no compensatory mechanisms. The volume of the left ventricle is the same. Because of that, there is increased pressures or elevated pressures at the end diastole. So elevated end diastole pressures in the left ventricle that exerts the backward pressures into the left atrium. So left atrial pressures are elevated. So backward pressures over the pulmonary veins, pulmonary congestion. So usually patient presented with sudden onset of breathlessness or chest pain, a cough with expectoration, what we discussed in acute MI. We'll discuss later. Okay. Then, and the second, if you look at the right side picture, here it's a chronic aortic regurgitation where the left ventricular chamber is dilated. Because it's a gradually progressive, the left ventricle compensate or accommodate to the amounts of blood that is received from the aorta and also left atrium. So there is a chamber dilatation and at the same time chamber hypertrophy. The pressures in the left ventricle may be normal or may be elevated during the phase of decompensation. What happened here? If you see, it exerts the backward pressures in the left atrium. The left atrial chamber dilatation is there, or there is a hypertrophy of the left atrium, and left atrial maintains the pressures within normal or may be increased whenever there is a decompensated state. Only decompensated state patient presented with pulmonary congestion. This difference between the acute and the chronic. Okay, then we'll move on to the what are the hemodynamic responses in chronic decompensated or chronic compensated aortic regurgitation. We are not going to the acute, but we only discuss the chronic compensated to the chronic decompensated. So what happened? The chronic compensated left ventricular and diastolic volumes are increased in both the conditions, whether it is a compensated or decompensated. LV compliance is increased in both the conditions, that is compensated and decompensated. But what happened to the end diastolic pressures? Left ventricular end diastolic pressures are mild, but these mild increased left ventricular diastolic pressures with normal compliance and patient able to maintain the cardiac output or stroke volume here. But in case of chronic decompensated, there is a marked increase in the left ventricular end diastolic pressures that leading to pulmonary congestion and failure. And the forward stroke volume, here in the chronic compensated, what we discussed during the phase where the end diastolic volume pressures are maintained, the now stroke volume is maintained. But in case of decompensated, left ventricle contractile dysfunction or left ventricle unable to pump the blood into the aorta or systemic circulation, that leading to decreased stroke volume or decreased cardiac output. This is the difference between the chronic compensated to the chronic decompensated aortic regurgitation. Okay, then coming to the symptomatology. Symptoms, it's relatively asymptomatic patients because already discussed aortic regurgitation after the stage of decompensation, that is before the development of decompensation, there are no symptoms. Only after the development of decompensation, patient has the symptoms. But the patient had a palpitations, especially on lying down posture, before the development of symptoms of aortic regurgitation. So the palpitations are mainly due to volume overload. That is left ventricular volume overload, or maybe sinus tachycardia, or maybe exertion or emotions, or sometimes the left ventricular chamber induces ventricular premature contractions. All these induces the palpitation, but these palpitations are unnoticed by the patients. So it may persist before the development of symptoms of the aortic regurgitation. The earliest symptom of aortic regurgitation is exertional dyspnea, when there is a diminished cardiac function or left ventricular systolic dysfunction. After that, patient developed orthopnea and PND and excessive diaphoresis. These are the initial manifestations. And second manifestation is anginal chest pain. 20% of the patients are presented with anginal chest pain rather than the dyspnea. Maybe pain during rest or maybe exertion. And why there is an anginal chest pain? There is because here the left ventricular hypertrophy is there, dilatation is there, but the demand by the myocardium is more, but the supply during the diastolic phase is low. The mismatch between demand and the supply that leading to a underperfusion of coronaries, leading to anginal chest pain. That is about the angina. And third one, syncope. Syncope, usually 5 to 10% of the patients are presented with syncope. Then patients presented with the congestive heart failure. The symptoms of congestive heart failure already discussed by Suresh sir. That's easy fatigability, pedal edema, breathlessness, orthopnea, PND, cough with expectoration. All these are the symptoms of the congestive heart failure. Okay, these are the classical symptoms of AR. One is palpitations, exertional dyspnea, or with orthopnea, PND, and anginal chest pain, syncope. Later, patient presented with congestive heart failure. Then, on examination, what are the examination findings? On examination, go with the general examination, systemic examination in proper way. So the physical examination findings are mainly due to widened pulse pressure in AR. What is widened pulse pressure? What is a normal pulse pressure? It's around 30 to 60 millimeter of mercury. That is the normal pulse pressure. Pulse pressure is the difference between the systolic pressure to the diastolic pressure. That is called pulse pressure. Widened pulse pressure means if the pulse pressure is more than 60, it is labeled as a widened pulse pressure. Why there is a widened pulse pressure in AR? One thing, there is increased stroke volume during the phase of systole that leading to high systolic pressure and low diastolic. Why there is a low diastolic means because of the runoff of the blood from the aorta into the left ventricle during the phase of ventricular diastole that leading to low diastolic pressures. So this is the cause for widened pulse pressure. So high stroke volume that leading to high systolic pressure. Diastolic runoff of the blood during the phase of ventricular diastole that leading to low diastolic pressures in the patient with AR. So high systole, low diastole that leads to the wide pulse pressure. So these the symptoms of examination findings are mainly due to widened pulse pressure. Okay. Then what are the examination findings? Examination, the pulse is high volume. High volume is because of the high stroke volume or high cardiac output. But the difference between high volume, so other valve disease that produces high volume pulse is mitral regurgitation. So how to differentiate between mitral regurgitation to the aortic regurgitation depending upon the pulse means the pulse here is high volume and collapsing nature or a water hammer pulse. So there's a difference. In mitral regurgitation, only high volume pulse are there, no collapsing nature. And wide pulse pressure, already discussed, there is high systolic to the low diastolic blood pressure. And the peripheral signs are there in aortic regurgitation. These peripheral signs are mainly due to wide pulse pressure. We'll discuss in the last on peripheral signs. And if you put your fingers over the carotid artery, there is a carotid thrill or a shudder, maybe palpable. Okay, it's common in AS, but also it's seen in AR. Why there is a carotid thrill in AS? Discussed in the previous class. There is turbulent flow across the valve leaflet that produces your carotid thrill or shudder in case of AS. Okay, then on examination. Examination, first you have to comment on apical impulse. Apical impulse is displaced out and down. What's the normal area of apical impulse? It is in the fifth left intercostal space, half an inch medial to the midclavicular line. Here, what happened to the left ventricle? Left ventricle is enlarged. That is, there is a hypertrophy of the left ventricle or chamber dilated. The dilated left ventricle gives appearance of out and down apical impulse. And here, the apical impulse is diffuse. What is diffuse? The apical impulse, apex occupies a single intercostal space less than 2.5 centimeters, it's called local. If it is occupies more than 2.5 centimeters in a single intercostal space or more than one intercostal space, it is called as a diffuse. So diffuse apical impulse again due to volume overload or left ventricular chamber dilatation. So apical impulse is displaced out and down and it is diffuse in nature. And if you put a finger over the apical impulse, it is hyperdynamic. Hyperdynamic apical impulse. Why there is a hyperdynamic apical impulse? Here the volume is overloaded or a hyperdynamic circulatory state here. So how do you decide whether the apical impulse is a hyperdynamic or a heaving or a tapping? It's depending upon the phase of systole. The apical impulse, how much the forward motion of the apical impulse. So if the apical impulse occupies 1/3 to 2/3 of the ventricular systole, that is called hyperdynamic. If less than 1/3, it is called tapping. If it is more than 2/3 of systole, it is called heaving. So here, heaving is usually seen in AS, already discussed in the previous class. Here, the apical impulse is hyperdynamic. How to assess clinically? If you put a finger over the apical impulse, if you feel the apical impulse with a high pressure, but without any sustained lift, that is called hyperdynamic. Or with a high pressure, goes back immediately, that is called hyperdynamic apical impulse clinically. Okay. And in palpation, there is a diastolic thrill may be palpable along the left sternal border in Finch's individual if the disease is severe or a orphan. These are the findings on palpation. So, inspection, one is apex displaced out and down, and apical impulse appears to be a diffuse apical impulse. And it is hyperdynamic in character, and there is a diastolic thrill may be palpable along with the left sternal border in case of valvular disease. Coming to the heart sounds. Heart sounds, usually first heart sound, on auscultation, you had to comment on heart sounds. Second, you had to comment, is there an additional heart sounds? Third one, is there an additional sounds? Fourth one, murmur. Then, coming to the heart sounds, first heart sound is here soft. So, regarding first heart sound, we don't discuss in the AS. This one is normal. But here, the first heart sound is soft. Why there is a soft first sound? The first heart sound is mainly due to closure of mitral and tricuspid valve leaflet. You know very well. First heart sound, the mitral valve leaflet is closed early because of the increased diastolic pressures, left ventricular and diastolic pressures. So because of increased left ventricular diastolic pressures, there is less valve expression that leading to soft S1. So early closure and increased pressures that leading to soft S1 in case of AR. Then coming to the second heart sound. Second heart sound, here it is soft or maybe soft, absent when the valve is involved. Or valve means the underlying etiology is a valve leaflet or a cusp. A2 is normal or accentuated when the root is involved. This is the difference between the root or a leaflet, whether leaflet is involved or root is involved. Here, there is a delayed A2 because that same thing we discussed in aortic stenosis also, because prolonged LV ejection time to empty the left ventricle, that leading to delayed closure. Because of delayed closure, maybe second heart sound heard as a single or maybe a paradoxical split sometimes. Okay, that's it. Second. The P2 component, already we discussed A to P2 in the A session. Because of that, I am not discussed here. The P2 component, the pulmonary component may be masked by the early diastolic murmur. The early diastolic murmur is start, we'll discuss later. Okay, these are the findings in the second heart sound. Second heart sound, A2 may be a soft or absent when the valve is involved. A2 normal or may be accentuated when the root is involved. That's the difference between valve to the root. And sometimes delayed A2 that due to either increased LV ejection time or maybe sometimes because of increased pressures, it may heard as a single or sometimes maybe a paradoxical split because of it's all depending upon the pressures in the left ventricle. And P2 may be obscured or masked by the early diastolic murmur of the AR. These are the auscultatory findings. Then coming to the third heart sound usually heard when patient is in a decompensated state. It's mainly discussed already, LV systolic dysfunction or LV failure that produces your third heart sound. Fourth heart sound again, maybe here the left atrium is involved, it will contractile abnormalities or ventricular diastolic abnormalities produces your fourth heart sound. Again, S3, S4 heart sounds are heard in patients with AR in a decompensated state. Okay. Apart from these sounds, you may heard a systolic ejection sound whenever there is a abrupt distension of the aorta by increased stroke volume. It may be sometimes systolic ejection sound. Okay, then coming to the number. So sounds S1, S2, S3, S4. S3, S4 are heard during decompensated state. S1 is soft and S2 is A2 may be absent or maybe accentuated or normal or a paradoxical split or a single sound. It's all depending upon the structure is involved. Okay, then coming to the murmur. Murmur in AR, early diastolic murmur, you have to remember here it is a regurgitation. In case of mitral regurgitation, mitral also regurgitation. In mitral regurgitation, there is systolic murmur. Here there is a diastolic murmur. So remember, the murmur is mainly due to where is the defect? Defect in a systolic phase or the defect in a diastolic phase. Here the defect is in diastolic phase. There in my MR, defect is in systolic phase. Okay, so murmur. In aortic regurgitation, early diastolic murmur is audible. It's immediately after second heart sound. There is a high-pitched blowing murmur, high-pitched blowing murmur, and it is a decrescendo nature. Decrescendo means there is a high intensity immediately after A2, then the intensity is getting slow up to in a mid-diastole or up to late systole. It's most audible in sitting, leaning forward with a diaphragm of the step and loudest at the left sternal border. Why left sternal border? If the murmur is um, better heard in left sternal border or left third and fourth spaces, probably due to aortic wall leaflet involved. If the murmur is best heard on the right side, second or third intercostal spaces, probably due to aortic root involvement. This is again a difference between how to differentiate root or wall. Okay. Then here the duration of murmur again correlates with the severity of the disease. The duration of murmur is increases, the severity of the AR is increases. But the loudness doesn't correlate with the severity. Then there is a if there is a perforation of the aortic wall leaflet or aorticals that produce a musical murmur that is called Puindo murmur or seagull murmur. So Puindo murmur means musical quality of the murmur due to perforation of the leaflet. Okay, then whole sessile murmur means the diastolic murmur of AR that is or predominantly heard in the left axilla that is called whole sessile murmur. These two we have to remember, Puindo murmur and what is whole sessile murmur. Okay, then the murmur of AR, what I discussed already. If the murmur is best heard along with the left sternal border, that is third or fourth intercostal space, you have to suspect there is a primary valvular pathology, that is aortic regurgitation is mainly due to valvular abnormality, that is called Harvey's sign. If the murmur is best heard on the right side, right third and fourth intercostal spaces, probably you suspect there is aortic root dilatation. Okay, aortic root involvement, aortic root dilatation, aortic ascending aneurysms, anything that produces the AR. So, in decompensated state, the murmur may be shortened. Then, what is Austin Flint murmur? You have to again remember this name, Austin Flint murmur. Austin Flint murmur is a diastolic murmur. It's a low pitched, mid or late diastolic murmur that is heard in the apical area in AR patients, aortic regurgitation patients. Why there is a mid diastolic murmur or a late diastolic murmur in apical area in AR is mainly in case of aortic regurgitation, the jet of the blood from the aorta that pushes the anterior mitral valve leaflet that leading to functional mitral stenosis that produces your diastolic murmur. So ARZ that pushes the anterior mitral leaflet, that leading to your narrowed mitral valve leaflet, that causes your late diastolic murmur. So you have to remember what are the different murmurs in the mitral regurgitation, aortic regurgitation. One is early diastolic murmur. It's normally heard in AR. What is Cooing-Doe murmur? If the cusp is perforated, that produces a musical quality, that is called Cooing-Doe murmur. What is Cole-Cecil murmur? Cole-Cecil murmur, if the diastolic murmur is best heard in the apical area, that is called, axilla, that is called Cole-Cecil murmur. Austin-Flint murmur, the mid-diastolic or late diastolic murmur is heard in the apical area in case of AR, that is called Austin-Flint murmur. So what are the differential diagnoses of mid-diastolic murmur in apex? One is mitral stenosis. You know very well, there is a mid-diastolic murmur in the apical area. And the second one, Austin-Flint murmur, that is heard in the aortic regurgitation. And the functional murmur in case of ASD. All these are the differential diagnoses of mid-diastolic murmur in the mitral area. Okay, so this is about the auscultation. Then coming to the peripheral signs of AR. All these things, it's very difficult to remember all these names. You have to remember some important signs. One is lighthouse sign. What is lighthouse sign? There is alternate flushing and blanching of the forehead, that is called, you remember from top to bottom. One is lighthouse sign, that is alternate flushing and blanching of the forehead, that is called lighthouse sign. And second one is Becker sign. Becker sign is visible systolic pulsations of the retinal arteries. Usually won't see, it's visible during the fundoscopy only. So Landolfi's sign, there is a change in pupil size with each systole. There is dilatation and contraction of the pupil, that is called Landolfi's sign. De Musset sign, there is bobbing motion of the, that is nodding, head nodding motion of the patients with each heartbeat, that is called De Musset sign. And Muller's, the visible systolic pulsations of the uvula, that is uvular pulsations with each heartbeat, again Muller's sign. Corrigan sign, there is a dancing carotids in the neck. Among these, you have to remember lighthouse sign, that is alternate flushing, blanching of forehead, and De Musset's head nodding, Muller's visible pulsations of the uvula, Corrigan sign, that is dancing carotids. You have to remember all these things. Then Corrigan's pulse or water hammer pulse, what we discussed in the general examination. So they palpate the, usually for special character, we have to palpate the carotid, but here we have to palpate the brachial of the radial arteries. Here, abrupt distension and quick collapse of the pulse on palpation, that is called Corrigan's pulse. And pulses vociferance. Vociferance means two peaks in systole. That's usually seen in a combined disease, AS and AR, and maybe it is seen in severe AR also. Okay, pulses vociferance means two strokes or two waves in systole. Okay, then Hill sign. Hill sign, the difference between the systolic pressure of the lower extremity to the upper extremity, that is Hill sign. If it is more than 20 millimeter, it's usually less than 20. If it is more than 20, it's mild AR. More than 40, it is moderate AR. If more than 60 mm of mercury, it is called severe AR, depending upon the difference in the pressures between lower to the upper. Then other signs, pinky sign, the visible pulsations of the fingernails or finger nails, or if you compress with a glass cell over the lip, that again produces alternate blanching or pulsations may be visible. That is called pinky sign. Their heart sign, visible systolic pulsations of the spleen. Rosenbach's, visible systolic pulsations of the liver. Traub sign, that is pistol short sign. When you feel the femorals, there is a bombing sounds or high volume, that is called Traub sign. And de Rosier's sign, again, input your straight over the femoral artery. If you compress proximal, there is a systolic murmur is audible. If you compress and distally, you may hear diastolic murmur. That is called de Rosier's murmur. But remember the 3 Ds: distal compression, diastolic murmur is called de Rosier's murmur. Okay, so these are the signs of peripheral signs of aortic regurgitation. Why all these peripheral signs? Already discussed. Because of the wide pulse pressure, you may get all these peripheral signs. So among these, you have to remember lighthouse sign and demosets, Muller's, Corrigan pulse, pulsus decifferens, Hill sign, and trap sign, Durogelis murmur. All these are you have to remember. These are the more important one. All these things you may ask in the clinicals or examination. Okay. Then coming to the how do you um, assess or before going to assessment, what are the causes of AR with a normal or a low pulse pressure? We discussed AR shows there is a widened pulse pressure, but here this AR with a normal or a low pulse pressure is mainly due to one is acute AR. You suspect acute AR in that individual, or AR with a combined lesion like AS or severe MS. You may heard um, a normal or maybe low pulse pressure you may get. And aortic regurgitation with congestive heart failure, you may get normal or a low pulse pressure. Aortic regurgitation with systemic hypertension, you may get normal or low pulse pressure because of the increased diastolic pressures in the systemic hypertension. These are some of the causes of aortic regurgitation with normal or low pulse pressure. One is acute AR, second one acute AR with combined lesions of ASR, MS, acute, uh, aortic regurgitation with congestive heart failure, aortic regurgitation with systemic hypertension. These are the causes of normal or low pulse pressure. Then, how do you assess the severity of the AR? By clinically. I'm not discussed about, depending on the investigations I'm discussing here. How do you assess the clinically severity? One is peripheral signs. If the peripheral signs are there, you may there is a severity of the AR or severe AR. Left ventricular size. How do you assess left ventricular size? Depending upon the shift of the apex, that is diffuse apical impulse with shift out and down apex shows there is a severity of the AR in the individual. And presence of S3 or S4 again shows there is a left ventricular systolic dysfunction. Again, that's the one finding that shows there is a severity of the AR. Then long-standing murmur that again shows there is a severity of the underlying disease. And if there is a functional murmur of mid-diastolic or late diastolic murmur in the apex, that is called ostinato murmur. All these things shows there is a severity of AR in the individual. One is peripheral signs, left ventricular size, presence of S3, long duration of diastolic murmur, and ostinato murmur. All these things gives a clue of the patient is suffering with severe chronic AR. Then investigations and management aspects we'll discuss in the next class. Already I told what are the investigations required to diagnose a patient with a disease, valvular disease. One is chest X-ray and second one ECG and 2D echo. Depending on these investigations, how to assess the severity of the disease and what is the management plan for the medical or surgical management. So what surgeries depending upon the defect, whether it's a valve or whether it's a root, we'll discuss in the next class. Okay, thank you.